Matthew Holt, speaking with old friend Aneesh Chopra. Aneesh, former CTO of the US, these days head strategy officer at Arcadia, having been acquired when Care Journey was acquired.
Yes.
Okay, Aneesh, you threatened this a couple of months ago when we spoke, and we're going to talk about Medicare Advantage, which is the part of American healthcare that traditionally has been the most profitable and probably some of the most controversial. Needs some changes. You guys were involved in a couple of papers that just came out looking at some of the data that you've worked on with CMS, with the APG group of Medicare clinics, etc. The big picture question here is that there's been a long rumbling debate, starting with sort of MedPAC and the Medicare trustees about does Medicare Advantage save the country money, does it cost the country money? There's been tons of words spilled in Health Affairs by Don Berwick and Rick Gilfillan, and on my blog by George Albus and others saying, and no one seems to be able to agree, right? What did you guys look at? And what was the tell me about the results of these papers, and give me a flavor about, the micro that you guys just looked at, and then we'll talk about the macro.
Absolutely. Well, the micro question is a subset of Medicare Advantage, is a portion of Medicare Advantage that looks a lot more like value-based care. That is to say, it's a stage 4 healthcare learning and action network, high aligned program between the payer and the provider. We call that capitation. And in those programs, patients, we were looking to see whether they were getting better outcomes for the dollars invested. And what you found in that research is, first of all, it's not public which groups of doctors are in capitated agreements with health plans. So the hard part was getting permission from a group of physician networks to disclose this information. But once we were able to do that in a research study, we were able to then go into the publicly available Medicare Encounters database, so not a proprietary database, a public database, and compare same doctor, but different payment model. What were the net observable outcomes on about 18 key quality indicators? And the stuff that we always track, avoidable admissions, PQIs, and so forth. And the answer was, for 16 out of the 18, Medicare Advantage had not just slight, but in cases, double-digit performance improvements on utilization rates relative to the same doctor's performance in the fee-for-service insurance model.
Now, in that fee-for-service model, is that Medicare Advantage paying fee-for-service?
Medicare Advantage fee-for-service.
This is still the same Medicare Advantage members.
That's right.
Right.
So the key question is, Medicare Advantage has been thought of as a single monolith in all the policy debate. Is Medicare Advantage better than traditional Medicare? And in reality, we don't have one Medicare Advantage program. We have many layers of programs. And in this case, capitated MA did deliver meaningful improvements on a series of well-understood quality measures. That's the positive. Now, obviously, there's a policy debate in the aggregate. When you get to the macro, what is it that we do today to compensate these groups? How much does risk adjustment play? And what can you do with the financial contribution to risk adjustment to reinvest those dollars to bend that curve? And that's a big part of the discussion we should have.
So before we get there, Humana for ages has been putting out information about it, and I've written about this, Medicare Advantage overall.
That's right.
Ballpark, a third of it is capitated, a third of it is basically fee-for-service, and a third of it is some mix in the middle.
That's right.
And they've compared their value-based capitated bit with the rest of it. It hasn't had much cost differential. They've made a bunch of mentions about intensive use of primary care services, reduction in hospitalization, all the rest of it. Doesn't seem to change that much in cost. You guys didn't look at cost, you looked at quality.
Outcomes.
Outcomes, right.
The reason for this is in the publicly available data, the actual unit price for a service is not disclosed. So you can infer if the services were paid at the traditional Medicare rates, this is what the cost would be, and it would be lower in the data that we had shared for a good chunk of the population. I think the key is, whether it be the Humana study or the study that we worked on with APG, this is an area where we're going to see more transparency, and this is not the end of the research in this area, but it's the beginning, I think, of a pretty thoughtful paper to introduce a novel look at a subset of the Medicare Advantage population that more aligns with traditional Medicare ACO models. And so that conversation is a good one when we're having a debate about the future of CMMI, the future of value-based care, that we're contributing to this conversation, that in fact there are material, well-defined measures that can show utilization differences between these two payment models. One may not correlate, may not cause the other, but they certainly do correlate.
Okay, so bigger picture. You've got this sort of people talking past each other or about fee for service versus this, and in the middle of this, We have this incredible press focus, Wall Street Journal investigation, stat investigation, particularly about United, but obviously everyone's at this game around risk adjustment, whether it's done fraudulently, whether it's, how this correlates with, AI-based denials and God knows what, right? But certainly there are now DOJ investigations into United, whether they'll last with the new DOJ, who knows. But what is your sort of sense about what's happened in the real world of risk adjustment versus what should be happening?
Well, I've long felt that risk adjustment data should be part of the medical record. In fact, when Patrick Conway was in office, I believe he was still at the Center for Medicare or at CMMI, it was like 2013 or 14, I can't remember, second half of the Obama administration. There was a proposal to think about what to do with the data that comes out of these risk adjustment visits, these home visits. And at the time, even to this day, Matthew, they're treated as if they're just a clinical, financial, administrative visit. They're not part of the medical record. So I had suggested that we just treat that content as part of the medical record to be part of what is essentially the patient access API, so that that can be part of how that care pathway can be delivered. At the moment, CMS does not. They treat this as a completely administrative function. So to me, big picture, a fee-for-service fragmented system where each of these individual sub-incentives can balloon in whatever way they can does relate to a distorted program. But if you have an aligned model, like a coordinated care, accountable care model, I believe you want to have a more accurate and precise risk adjustment model as part of the benchmark formula. So hey, here's the budget for what the care will be under traditional math, and if you can improve this patient's outcome, you should be rewarded. And that alignment of incentives is what we saw in this paper having a material effect, and I hope that that will be the foundation of any reform, that reforms are easier to execute when the medical group is taking total cost of care responsibility. That avoids this issue of standalone home visits versus standalone primary care versus standalone specialty visits.
Yeah, and I think if you go back sometime, the ChenMed folks were talking about, let's have this be part of the record, let's have this be part of the visit, let's not have a separate piece. We still do have significant amounts of nurses wandering around America doing these visits, and we have a lot of controversy with that. What is your, putting you on the spot, it looks like Medicare Advantage, should be cheaper. There's a lot of, there is a lot of stuff to Medicare Advantage patients.
Or to deliver the gains. The question really is about where do the advantages, where do those savings get accrued?
Well, some of them clearly go to the patient. Some of them go to other services to the patient. Some of them, hopefully, we'll go back to the taxpayer. That's a lot of argument about that. No one's done a very good job of quantifying those three different chunks. But it also seems to me that you've got a bunch of other stuff going on in fee for service that no one's really reporting on. We know there's a lot of fraud, waste, and abuse. We haven't mentioned Doge yet, but they can probably take a look at that. At what point do you think we get to a unified view of this, where we actually agree on the data and say, look, we have understanding of what is happening across the entire Medicare population, and that these ways of doing it, if it be capitated care in integrated groups or whatever it is, seem to have produced better outcomes, and we should add more to that. We've had God knows how many different experiments on the CMMI. I mean, why is this taking so long?
It is, at the foundation level, an encounter/claims-based system on which to judge the relative performance of a health program is not sufficient. We've invested billions of dollars into clinical data, lab values, clinical diagnoses, notes. We should be able to extract from that corpus of information a much more granular profile about this patient's health status, and that patients like that individual usually get the following outcomes at whatever cost. And did this program, MA or individual medical group or ACO network model, improve upon that expected outcome? That's the holy grail. And the Biden administration put out an RFI. What do we do to get more data out of the Medicare Advantage system so that we can get a better handle on what's working and what's not working? If we don't do that with clinical data in the mix, then we've missed the chapter of Medicare reform that's desperate. We're not going to cut our way out of this deficit problem. Medicare Advantage is not going to, if you don't have a clear understanding about what the total health expected conditions are and really what the evidence-based medicine should do to get their better care, you're not going to make a dent in the system. So what do I need? I need a foundation of clinical data and claims data linked at the patient level that tell their story. We want to have an economic model that aligns the incentives so medical groups can go reduce that burden, preferably with the support of a health plan that wraps that medical group with support services, and that team should be able to measure their performance against the expected alternative. And if we can reward better outcomes, that may save 10, 20% out of the Medicare growth rate, which is frankly what we need to keep it stable. And that to me is my hope.
All right, two questions. One is, let me answer. Just going to pause there. So two questions.
Yeah.
First one, if, as I think you suspect and I suspect, some kind of integrated medical group at risk, paying attention to the whole patient is more effective, efficient, better for the patient and probably costs less.
Yes.
How close, I mean, we've been talking about this stuff for 35 years.
That's right.
How close do you think we are to getting enough of America's doctors and providers into such a system that we can actually manage it at scale?
The billion-dollar question is the commercial population.
More like $1 trillion, but go on.
Yeah, it is $1 trillion question. To me, if you asked me 3 years ago, the answer was, can you please join the MSSP program? Can you do shared savings? Can you do something? And it's just very difficult for an individual employer to administer and to have any scale. They have very little coverage on a per doctor basis, given that employees live all over the country. So that meant a little frustration. We couldn't have the same payment model to bring the commercial lives and the MA lives and the Medicare lives together. Well, there's now a new model, and that is born out of the price transparency movement. Pay for quality. One of our members, Vanderbilt, and the Arcadia family, they've now developed dozens of commercial bundles that piece together clinically relevant services through an episode of care, like a pregnancy. And they say, look, I may not take a capitated payment, but I'll take a bundled episode payment. And that will allows me to bring those populations into the fold. So as ACO networks have commercial and Medicare populations with different economic models, but all in an aligned program, then you can just justify the investments in infrastructure and change management to the practice. So you're capturing a larger share of their population. Anyone that does a third of their business one way and 2/3 another way, really hard to have that proverbial foot in two canoes. So this is a critical part of the equation. And I think this is the year when the ERISA fiduciary rulings come out from all the different court cases. I think the net effect is going to be employers have to do more on quality. And once we awaken the employer quality giant, then it will result in value-based, if you will, in air quotes, populations that can be managed by the same ACO networks that are willing to take capitated agreements. And that'll make an economic justification for the change to get doctors to want to be more active participant in it.
So you're being bipartisan here between George Halverson and Rick Gilfillan and Don Bowie,
Look, and the reality is, Medicare Advantage in many ways is the greatest policy invention in the last 30 years. Why? The specific noun of it may be up for, we got to tweak it, improve it, mend it, don't end it, but the structure of it as a public-private partnership, when you align the incentives, you get better outcomes. And it has all the features. It's got an economic model, it's got a quality and outcomes measurement model, it's got a payer-provider connectivity model. So you got all these elements wrapped into a program, and at the end of the day, it's done quite well in aggregate. Now, the debate is, do consumers get 95% of the surplus, 93% of the surplus? Okay, that's a debate, but it ain't zero, it ain't 50, they're getting a good chunk. And so we would not have these benefits in traditional Medicare today for half of the population if it weren't for the Medicare Advantage program.
All right, last question. We have a, how do I say this? Unusual choice for both head of HHS and head of CMS.
Yes.
Yeah, I mean, okay, I know Oz is on record as saying that, Medicare Advantage for all would be a good idea.
Yes.
I mean, God knows if anyone can speculate at all about what the hell's happening right now in the current administration with Elon running around doing who knows what. What's your guess? I mean, you said a lot of things that could come out and seem to have bipartisan support, and transparency thing was a Trump initiation. But what's your guess as to what actually is going to come out in terms of policy?
I think the MAHA executive order, which is what RFK Jr. ran on, could have been written by President Obama.
Sure.
That's what I think.
Or his wife.
Or his wife. In fact, the very first challenge.gov initiative I worked on was a Let's Move challenge, which basically said take all the nutrition data out of the USDA and build apps to give kids the information they need to eat healthier. So literally, the Michelle Obama, First Lady, healthy food challenge literally could be deployed in the Trump administration, and that's how collaborative this looks like. And to me, their commitment to open data, transparency, and a focus on chronic disease, there's no other way to wrap a business model around doing better, and that's value-based care. So we got a bipartisan commitment with slightly different, macro perspectives, different personalities, but we can work as an industry towards that same North Star.
Hey, and Kennedy even came out and said he supported the MMR vaccine, which I know is a plus at least.
Yes, for the public health advocates, that's an area where there's a lot of anxiety.
Well, we'll see how that all plays out. But this Medicare Advantage thing, it's at least got to be understood and then hopefully solved.
More transparency and the mechanisms of reform to move us towards a North Star of value-based care.
Brilliant. I've been talking with Aneesh Chopra, Chief Strategy Officer at Arcadia. Aneesh, thanks for your time.
Always. Thank you, brother.